Hi, my name is Sidra Shah, and I'm a PGY2 internal medicine resident at Mercy Health St. Rita's Medical Center in Lima, Ohio. Today I would like to discuss an interesting case called endocarditis of the forgotten valve, vacuum-assisted aspiration, angiovac of the eustachian valve. Infective endocarditis is typically caused by staphylococcal bacteremia and involves infection of the endocardial lining of the heart. The majority of infective endocarditis, roughly 80 to 90%, involves the left side of the heart, with right-sided infective endocarditis accounting for only about 5 to 10% of all cases. Right-sided infective endocarditis predominantly is seen in the setting of IV drug use, cardiac implantable device, or presence of underlying right-sided cardiac anomaly. Majority of these cases involve the tricuspid valve, followed by the pulmonic valve. However, a rare presentation involves the eustachian valve. This valve is a non-functional embryonic remnant that functions to direct fetal oxygenated blood towards the foraminal valley and typically regresses after birth, but may remain in 25% of people. In the setting of infective endocarditis refractory to antibiotics, angiovac is gaining increasing momentum as a treatment of choice over standard surgical intervention for debulking large vegetations. To our knowledge, we report the first case of eustachian valve endocarditis treated with angiovac. A 64-year-old male with a past medical history significant for end-stage renal disease on hemodialysis via tunnel catheter presented for right shoulder pain and hypoxia. 1 month prior, outside blood and urine cultures were positive for methicillin-sensitive Staphylococcal aureus, MSSA. At that time, he was treated with IV antibiotics and transitioned to oral cephalexin. During this admission, blood cultures were positive for MSSA in 2 samples again. TEE demonstrated an ejection fraction of 60 to 65% and a large independently mobile echogenic density consistent with vegetation, 3 cm by 1.6 cm on the eustachian valve. Due to his actively persistent bacteremia and multiple comorbidities, he was considered high risk for surgery. Therefore, he was deemed a candidate for angiovac. A structural heart team approach was undertaken. He was brought to the hybrid operating room and placed under general anesthesia, intubated, and intraprocedural TE was performed. A 26 French core dry seal sheath was inserted via the right internal jugular vein, and a 17 French left femoral venous return cannula was inserted via standard modified Seldinger technique. A standard C20 angiovac cannula was prepped and inserted into the 26 French sheath. Using fluoroscopy and TE guidance, the C20 cannula was advanced towards the mass, and using a combination of 2D explained 3D imaging, the entire vegetation was aspirated from the eustachian valve. Eustachian valve endocarditis is a rare entity with the first reported case in 1986. Since then, roughly 37 cases have been reported. This rare presentation is mostly attributed to the low prevalence of eustachian valve in adults. Eustachian valve endocarditis is treated similarly to other right-sided infective endocarditis presentations. Therapy involves a prolonged 2 to 6 week course of antibiotics. At times, infective endocarditis remain refractory to antibiotics, and surgery may be needed. However, angiovac has gained increased momentum as a means of effective and minimally invasive alternatives to surgical intervention in high-risk surgical candidates. The system is a percutaneous transcatheter aspiration system that functions to suction out blood and debris through an inline filter before being returned to the body. By doing so, it debulks large and persistent vegetations, allowing for decreased bacterial load, increasing antibiotic efficacy, and reducing risk of recurrence. The eustachian valve, although thought to be benign, in the correct clinical scenario predisposes patients to endocarditis and merits aggressive therapies. This case provides evidence that with the structural heart team approach, angiovac provides another tool to successfully manage large vegetations in patients who are not candidates for surgical intervention.